Welcome to Voice for Infection Prevention, where we explore the latest developments, challenges, and insights in the field of infection prevention and control. With a passion for promoting patient safety and healthcare excellence, we're excited to bring you engaging discussions with experts, leaders, and innovators in the field. So whether you're a seasoned professional or just beginning your journey in infection prevention, welcome to the conversation. This is Voice for Infection Prevention.
Welcome back to Voice for Infection Prevention. Today I'm joined by Maureen Spencer, a longtime leader in infection prevention whose career has spanned decades of change across healthcare, from the early days of hospital infection control to corporate leadership, consulting, education, and beyond. Maureen's story is especially unique because she entered the field at a remarkably young age, helping build an infection prevention program early in her career and going on to lead across academic medical centers, specialty hospitals, and multi-hospital systems. Along the way, she developed a perspective on infection prevention that is both deeply practical and deeply human, shaped by years of clinical experience, leadership, teaching, and a strong belief that changing behavior is at the heart of this work. In this conversation, Maureen shares how the profession has evolved over time and what she believes infection prevention has gotten right, where she believes the field may have gone off track, and why training, reporting structure, and professional identity still matter so much today. We also talk about team design, the value of strong clinical understanding, and her belief that effective infection prevention programs are built not just on data, but on education, influence, relationship building, and culture change. If you're interested in the history of the profession, leadership in infection prevention, and thoughtful perspectives on cool. All right, Maureen. So, thanks for doing this. I'm excited to chat for a bit, but I'm going to start off with the question that I've asked really everybody that's come on, and I'm just curious as to how in the world you fell into infection prevention. That seems to be the thing. Or how'd you find infection prevention? What's your story? How'd you get into this field?
Found me. That's what happened. So back when I was 15 years old, I got it. I was working in a nursing home, actually, since the time I was 14. And one of my high school classmates said, my aunt is the head of microbiology at Boston City Hospital in the lab, and they're looking for planters, people to plant the cultures. Would you be interested? Well, the pay was so much more than what I was doing in a nursing home, lugging around patients and cleaning them and everything. So that was kind of my intro to nursing. But I took the job and absolutely fell in love with it. I'm working, and I get into nursing school, and I'm still working in the micro lab. So I get a call from the administrator of Kearney Hospital, which was about a 300-bed hospital at the time in Boston. And so we hear that you are the nursing student in our micro lab, and we need to set up an infection prevention program. Well, we called infection control back then. We called infection control nurses. And would you be interested? I'm like, yeah, that sounds fascinating. I could mix nursing with infection prevention. So I started when I was 20, right out of nursing school, literally. And at the same time, I started teaching yoga at that hospital. So everywhere I have worked, I have taught yoga, including Mass General, which I'll get to that level there. But it was, the biggest challenge was my emotional immaturity. I didn't really know how to handle the sharks of nursing. They're tough, especially nurse managers, and it's really going to gobble and eat you up. So she really took me on under her wing to help me, and then sent me to the CDC. And we had a 1200 G course by Claire Capage back then, which was excellent. I mean, to say that you went and trained at the CDC was huge. So that's how I started infection prevention. And I get a phone call from Carol DeMille, who was the head of Mass General at Mass General's infection prevention. She said, "Hey, I hear you're this new infection prevention nurse over at Kearney Hospital." I said, "Yeah." She goes, "Well, we're just starting this chapter. We're going to start, there's an association we're starting, and there's a chapter. Would you like to get involved?" And so she took me under her wing. But I got involved with FAPIC very early on. I went on to this career. After that, I went to the VA in West Roxbury, Massachusetts, and that was specialized in open heart surgery and spinal cord injury. So I stayed there for about 7 years, and then I moved on to Mass General Hospital in 85, and I was there for 11 years. And a lot went on there during infection control from 85 to 96, just things that happened in our career. And then I got laid off when there was a corporate downsizing of the Brigham, the Brigham and Women's Hospital, Mass General, and 22 nurse directors. We lost our jobs, and they gave them to doctors because they had too many doctors to lay. They didn't want to lay any doctors off, so they thought, well, all the clinic nurse directors lost their job. I got hit. Within 2 years they replaced it because they knew they couldn't do our job.
Right.
And so what I did was took a break and said, I'm going to open a yoga studio. I'm done. I was so worn out. So absolutely worn out, especially from implementing bloodborne pathogen standard back then. That was a huge undertaking that people today have no idea what IPs went through to implement that. So I did that for 7 years. And then I went into an orthopedic hospital up in Boston because I didn't want to renew my lease because of everything I learned in the community. Patients who really didn't understand their disease, didn't understand how they got sick or what medications they were on. And I was just like, I got to get back into healthcare to teach them what I learned these 7 years working with the community. And I was doing like anywhere from 30 to 40 Reiki sessions a week, teaching yoga teacher training certification, Reiki certification. That was the big, but I learned a lot. I just learned also how to be a businesswoman, an entrepreneur, and run a business, very successful.
Yeah.
And so everybody was very upset that I abandoned them. But I went to New England Baptist Hospital, which is an orthopedic hospital in Boston. And they did at that time over 12,000 orthopedic cases a year. So I specialized in orthopedics specifically. I mean, we did do general surgery and gynae, but for the most part, it was orthopedics. And then I went on to become a corporate director at UHS after 7 years. So I lived my life 7-year journeys. On the 5th year, you'll start getting antsy, whether it's in a relationship, in a job, because of this journey through what we call the energy centers of the body called the chakras. And you get to a point where, is this all it is? I need something more stimulating. So you either have a kid or you buy a house or you get married. I literally just got married in September after being with my fiance for 7 years. I made him wait 7 years. I have this 7-year thing, and I'm kind of running out of time now, but we just got married in September. So from there, I was there for corporate director of 25 hospitals in 7 states. And so those 7 years, I traveled every week. I would go on Monday to the airport and come home on Friday. And I learned a lot about healthcare across the United States. And I learned a lot about my IPs who had a 50% turnover every year and which ones were the ones that left because of lack of clinical background. And from there, I always wanted to work in industry. And before I ended my career, so I got a job with a company called Accelerate Diagnostics in Tucson. And I was their director of clinical implementation and education. And I would be the one to travel with the sales reps to try to convince microbiology labs to adopt this 7-hour blood culture test. You would know in 1 hour what the bug was and 6 hours the sensitivity. And we wait 2 to 4 days for that result on it now. And we give them all kinds of antibiotics, which create C. diff and multiple drug-resistant organisms. And what a challenge that was to be on the other side and to see how sales reps are treated by professionals, how they use definitive healthcare, which is an amazing software to pull out all publicly reported information. We don't have that access to it in healthcare. Salesforce, how do they know who we all are? How do they fill out their blue forms, all these things they have to do for sales? Yep. You're not right now. And then I retired the end of 19, and then COVID hit. And so what I thought was going to be this nice little segue into a little bit of consulting became a huge bomb of consulting because they couldn't get in touch with IPs in the hospitals. So the group of us that were IP consultants started to get a lot of work. I worked with the departments of public health. I worked with the Marriott hotels. I worked with prisons and homeless shelters and you name it. I was doing really unique education on COVID, and surveys. I was doing surveys in nursing homes and places for the Department of Public Health. So then I met Peter Graves, who's an OR nurse from Dallas. He's a perioperative consultant. About in 2020, we were working on a large study with Premier, which started in 2019, on colorectal infections and whether hospitals had adopted the CDC guidelines. We looked at 7 elements, basic elements in those guidelines. And I was able to get 3 hospital systems to agree to join us. I started, Sue Barnes and I, she used to be the head of Kaiser, and I started a corporate IP director group in 2015, 10 years ago. And it's amazing to see where it's gone. And it's an interesting story how we showed up at APIC, and on the agenda it said consultants meeting. And so we went to the room and nobody was there. Literally, we were like, who set this up? So we get down to the desk, the APIC desk, and said, right here it says there's a consultant meeting. Who set this up? They're like, we don't know anything about that. I'm like, but there's a room set up. You paid for a room. And they're like, we have no idea. So I said to her, it's divine intervention. We're being told we need to set up an IP directors group. So I had the list of IP directors from an HPG task force I had been on for the GPO HPG for infection prevention products. So I reached out to them. We started with like 10 people. And now it's, I think APIC has taken it over and it's like 180 maybe. It's a big group now because they now have system directors and corporate directors.
Right.
So Peter and I then started to work together, collaborate on surgical site infection projects. And that's now where I'm at. My career is pretty much focused on the prevention of surgical site infections. And I work with a lot of companies that have products in that space. And we're trying to kind of showcase and role model the relationship that we should have between the OR and IPs. And what are the things that we look at when we do surveys? We actually go into hospitals and do surveys. If they have an outbreak, they'll get in touch with us. And it's more than Joint Commission or CMS. We are thorough. I mean, we look at everything. And I based it on what I did at UHS, the surveys we did there. And I was on a team of 7 of us, a corporate quality team that went every week to a hospital and did these surveys. So it's worked out well for those hospitals to see things that they didn't know through the 2 lenses of an IP and an OR director. So that's where I am now. I work a lot with ARN, quite a bit. And then, like I said, maybe 4. At the moment, there's just 4 vendors. We try to keep it just at 4, so we're not overwhelmed. Yeah. I do have a little bit of a life I'm trying to have semi-retired. So it's been fascinating to go, through all this. And even with the yoga, when I closed the studio, I made everything digitalized. So I have a yoga school training kit, a 350-page manual that shows the school how to train yoga teachers. I have a Reiki. And so I still walk in the realm of holistic nursing because I'm training right now to be a nurse coach. And I would love to, when I fully retire from infection control, I want to get back into holistic nursing and kind of do what I started with way back then, that patients just don't know anything about their infections, what's going on in the hospitals. They're being thrown out same-day surgeries, and there's just a big need for nursing education in the community. So I see myself ending on the sunset as a nurse coach. Life goes full circle if you think about it.
There you go. Yeah.
Every
7 years. And
fun career. Circle. I've absolutely loved it. I love infection prevention. Love it. I miss it. I wish I was still in a hospital, doing some of the stuff that I used to do. Yep.
And you've covered a lot of stuff that I want to dive into. So let me go back at the very beginning. All right. So you ended up at Kearney Hospital, infection control nurse. Was that a sole preventionist position?
Yeah.
Were you the first?
I didn't even have an infectious disease doctor. 2 years later, they hired Phil Carling, which Dr. Carling, a lot of people know from his work with the environment, CDC and environmental sampling, the DAZO. He actually developed the DAZO stamp. That's a fluorescent dye stamp that you can use. Yeah, he was the discoverer of that, manufacturer of that. But so then they hired him. So at least we had 2 of us with the secretary. That was in a 300-bed hospital.
Now, there wasn't an IP before you, correct?
No,
you were the first.
I set up their program, yeah.
Okay.
Yeah.
So, was somebody directing you, or was it just like you? Well, I think I should do this.
Well, that administrator, I would when the American Hospital Association came out with some infection prevention guidelines in the mid-70s, we had something to go on. And then Joint Commission came out with some, and it was called JACO back then versus just TJC. They came out with some guidelines and standards for infection prevention. And then we had the scenic study done by NHSN, by CDC and NNIS for nosocomial infections. So a lot of things started to get cooking there in the late 70s to the early 80s. But as things came out, we had an infection prevention committee. But it was interesting. We did a lot of environmental cultures back then. We cultured, oh my God, doorknobs and things in the operating room, things on the nursing unit, and then I would collect the infections, and we noted they don't match up. Like we're not seeing back then when you could eat off the floors in hospitals. They were so well staffed with EVS workers.
Interesting.
And this was a Catholic hospital, by the way. So my administrator was a nun. So, they make sure everything was just so clean and well supported. Not like today where maybe they should get back to environmental sampling, because the environment is a real challenge, as you know, in hospitals today because of the lack of really good disinfection and EVS staff support. So yeah, it was, I had to set that whole program up, and it was basically following these new guidelines that were coming out. There were 50 of us in New England, all of New England when we started. I don't know how many hospitals are in New England, but there's a lot. So it was just a very small group that hospitals actually started hiring. Then the word came out that Joint Commission and American Hospital wanted you to hire infection control nurses. We were all nurses back then. We might have had a couple of med techs, but we were all nurses. It was a nursing profession. I reported to the CNO. And as APIC went on, we were actually trying to develop this into a nursing clinical specialty. So we would have been called clinical specialists with a master's degree in nursing. But then APIC took off another track and called everybody an IP, which I have a lot of trouble with. I have real strong feelings about that. We can get to that.
And that, yeah, we'll come back to that because I want to hit in on that. Okay, so you spent time at the VA. After that, then worked your way back and you were a director at Mass General. When you were a director, was that just a director title and you were still a sole preventionist, or was there a budget for a team at that point that you were over?
When I first started, there were just
two of us. What did that job look like?
Yeah, so when I first started, we had 1,000 beds. We were in 3 cities. We had 22,000 employees, and there were 2 infection prevention nurses, infection control nurses, we were called. And we reported to a hospital epidemiologist. And we actually even had a laboratory connected with us where he did a lot of research with the infectious disease. He was an ID doctor as well. And so when the bloodborne pathogen interim guideline came out in the Federal Register in 89, that's when everything exploded. We needed more help. We got 2 more infection control nurses in. And we had to go to every single department throughout the entire campus and write down everything they did. They had to tell us every procedure that they did in that nursing unit, that laboratory, that wherever, radiology, respiratory, labor and delivery, oncology, you name it. It was probably, in my entire career, the best thing that ever happened to me. It was painstaking to do it, but I got to see the whole picture of everything people do. And then we had to guide them on their PPE. We had to write down what would be the personal protective equipment you would use to prevent infections in those kinds of tasks. And so then all the education had to get done, and all the policies and procedures had to get written. And for every one of those departments had to have a policy procedure listing their task analysis, we called it, and what the PPE would be. And so as time went on, we were able to get maybe 1 more position. Now I think have over 10, I think, in that department. And they don't have as many beds. They don't have 1,000 beds anymore. They're in maybe 500s. And I think last figure I heard they're in the 50,000 employees, but that could involve the Brigham as well. So yeah, it's a lot, but I don't, as much as it drove me crazy back then, I look back on it, and I think what would be good for new IPs is to do a task analysis in their hospital and say, I've got to review and update my bloodborne pathogen standard. So rather than just stamp it every year, actually do it as a project and say, I'm going to go back out and reassess. Do they really do all these things? Or have they added any procedures on, which I'm sure they have, that they're doing things in those laboratories or those departments that I don't know. And they would then be able to get a better appreciation of everything that's done in all these departments that could then lead them to understand maybe an outbreak investigation better. Say, oh, I remember I saw that was being done. And that's why when I had outbreaks, I knew that. I knew what anesthesia did. I knew the procedures we'd put in place for anesthesia to prevent infections. I had a horrible outbreak once, and I found out it was that anesthesia stopped using a particular piece of tubing that would have prevented bloodstream infections because they want to save money, and caused a 36-case outbreak of Pseudomonas senescens in cardiac surgery. I put a poster at APIC on it in 89, and people were like, oh my God, must have been awful. And it was. And then just because I knew, because of the task analysis, what they were supposed to do, I'm like, I wonder if they're not using that piece of tubing anymore between the calibration manometer and the stopcocks. And sure enough, they weren't. to save money in the budget. So that's what I mean about we have to get better clinical experience of knowing what should go on, what's going on in these departments. So that's one easy way to do it. Or Joint Commission resources templates, which is what I implemented at UHS. And I wrote 13 templates for 13 departments for IPs to go out once a month to those departments. And I said, just divvy it up 3 or 4 departments a week and fill this out and introduce yourself, know what they're doing, watch their procedures, get to know them so that you could, I was thinking similar to that task analysis, that this is another way to get them out of their office from sitting on computers doing NHS out into. And you know what's interesting? I knew Terry Horan was from New Hampshire, so we knew her very well. And I remember talking to her once, maybe 2 years after it was implemented, around 2010 is kind of when hospitals really got NHSN up and running. And I said, why did you not recommend this be done by data specialists? Why was this dumped on IP staff? And she said, we did recommend data analysts. We never intended for IPs to do this. This was not our intent. I know what the job entails. I did it. And unfortunately, hospitals just didn't want to hire back then. It was when the market crashed and it was really tight to get data analysts in to do that work. I trained my administrative assistant. I have never done NHSN, nor would I. I wouldn't. I would do the analysis afterwards. Okay, this looks like it's a case. Write it up and submit it, upload the surgical files. But we trained her how to do that. But I did the original epidemiology investigation. Right. So there are ways you can kind of get around it. But yeah, it's, in my opinion, it's kind of really put a damper on our jobs as educators and consultants and researchers.
Now, is there a fight against that right now? Or is that has everybody kind of moved past that and it's now just...
Well, I think now they try to figure out somebody maybe in quality, or they get data analysts. A lot of times maybe somebody with a new person with a master's of public health, that's an open doorway they can get into infection prevention, which I think is great. Get in, start to look at the infections, and they do that surveillance. And then, but because they're part of the team and they can start to learn the clinical aspects of infection prevention. So yeah, that's typically what we would see, is that somebody with a good data, sometimes quality nurses might get into it. It's unfortunate the way it happened, but it happened. So I think I wish we were stronger in saying, like I did, I'm not doing it. I am not going to waste my salary and my time at my career level to sit at a desk and upload surgical files and to enter all these data sheets. I'll go out and collect the infections and work with my ID doctor. I met with her twice a week. She called them infections. That was the other thing I was very strong about. I am not a doctor. I don't diagnose infections. And I see all the criteria. And sometimes I would call it an infection, and she'd say, no, let me explain to you why it's not. It's actually not in the joint. It's in the gutter. It's not down in the joint fluid. And even though it looks like an infection and there's purulent drainage coming out, that is not an infection. Now, we would have counted that. You just need to have that. And I'm very firm about that too. I know my scope of practice as a nurse. I don't diagnose infections. I wanted her name behind that to say, yes, I say that this is an HA. I will enter that into the system. But so I don't know what the answer is, but could be a good open door for a data analyst who then moves up to an infection prevention coordinator, who maybe eventually moves up to an infection prevention manager or director. And that's how I see our job. We're being left out. A lot of IPs are being left out of the administrative structure, the department head meetings or nurse managers meetings, because they don't have the title to be invited. And there's a language that you need to learn to talk to the C-suite. You need to know how to do executive summaries. You need to know how to talk to patients, what not to say to patients, what's not in your scope. I've seen that mistake made because they don't have that clinical training to say, I can't talk to a patient about their infection. I got to wait till the doctor has spoken. Just a lot that comes up that I've had to deal with in my career.
Now, this is about, so you did the directorship for, this one actually looks like closer to 11 years based on your LinkedIn resume here versus 7. But it looks like this is kind of where you made the shift into doing the yoga studio?
Well, I also did legal nurse consulting. So it was,
Yeah, I see that there.
yeah,
Yeah, you got two things going on at
right.
once. Tell me about the legal stuff.
So what happened is
Get it.
just before I was going to be laid off, it's like God was just like looking out for me. I get a call from a law firm down in Palm Beach, Florida. We have a
Okay.
huge outbreak of mediastinitis down here. And we need somebody at your level of expertise to work with us. So it was fascinating. I'm glad I did it. And yet I was super glad I did set up that yoga studio and learned how to be a nurse entrepreneur. Because when I got laid off from Mass General, they gave me 6 months of an outpatient placement service up in Boston. And I would go up there and I was hanging out with all these executives that got laid off from, there was a big chain called Bradley's that they got laid off from, or different corporations because of, the time period, things getting really tough back then. And I
Yeah.
learned a lot. They put me in the entrepreneurs group. A lot of these, mostly guys, I was one of the few women who wanted to set up their own construction companies or businesses, consulting businesses. So I learned a lot about, an LLC versus a C-suite versus, a C or an S corporation, and how to do your taxes, and, how to be self-employed and estimated tax returns, and things that really can overwhelm people, how to get health insurance, how to set up a 401k. You can do everything that you can do being stuck in a job on the outside.
Yeah.
And so then when I came back in, I didn't have fear. I knew that, okay, if something happened, I can just do it again. It's a great experience to run a company and be successful.
Yeah. I can certainly speak to that.
Right?
I'm curious your yoga studio though. My wife does it. I do it a fair amount. I mean, did you have the cleanest yoga studio in the city?
Yeah.
Like,
I cultured the yoga mats, if you can believe it, to prove to them
really?
how dirty they were. Oh my God, they were covered with organisms. Yeah, and the reason I did is it was an outbreak in San Francisco where they were doing naked yoga in this community, and they got MRSA boils and abscesses all over their buttocks, and it was on the yoga mats,
Oh my
sitting
God.
on yoga mats. Yeah, so I mean, yeah, it was very, very clean. I made them all clean. I used to take them home every week and wash them in the washing machine, 2 at a time, with bleach and clean them up. Yeah, that's funny.
And you mentioned you've got these like programs you've written out that people can kind of buy and
Yeah.
learn through
My
everything.
company's
Do you
called
have a section?
Finding Inner Peace, and it splits off to the Yoga School Kit, that website, Reiki certification, and then vibroacoustic sound healing, that's kind of hard to explain, but it's a very unique type of healing with a sound mat that shakes the
Gotcha.
body. And as it does, like when you're dancing or you're at a concert and you come out, just rejuvenated and like pumping energy,
Yeah.
depending on the kind of music it is. If it's really soft and classical music, very calm and mellow. If you're at a big rock concert, you're like ready to take on the world. So that's what we do. We would use the music based on their emotional state. So if they were grieving, there's music that will get the grief out, like a cello or something. Stringed instruments hit this area of the body. And if they need to get up and go, drumming music, if somebody's like really stagnant and depressed. I did over 14,000 healing sessions, and I know energy. I know what healthcare doesn't know. That's the problem. We need to integrate these two. That's what's missing in healthcare. We just go in and treat the symptoms, but nobody's saying, what is the body trying to tell me? And that's what I said earlier about infections. Infections to us is anger and arrogance. I mean, they don't wash their hands. They don't clean their equipment. They walk around with blood on them. It's arrogance, and it leads to infections. And so if you have a system, like when I went to New England Baptist Hospital, the CNO wanted me to teach Reiki to the nurses, and they saw the difference. So our infection rates were probably the lowest in the country. We were at 0.3 for 12,000 orthopedic cases a year.
Wow.
Because everybody worked so well together and everybody collaborated so well together. It became a whole different culture, But anyways, that's kind of hard to implement that in some places.
Well, why it's so hard to change the culture at a hospital? I mean, you mentioned arrogance. Like, is it arrogance? Is it, or like, do people not really understand the impact, or do people understand the impact and just don't want to take the time to do it because it's harder for them? I'm sure there's a mixture of all.
Yeah, it's lack of empathy. Money is energy. And so
Yeah.
right now, this whole greed in our culture, and and lack of money in healthcare has a very low vibration. And so you just feel people just give up, because of, yeah, this is the way it is. All they care about is money and the bottom line, and they don't really care about patients. And that's true. A lot of it's just survival. A lot of the nurses and doctors are in a survival mode. So I used to like the fact that I would train the nurses, because we'd walk in an ICU and see nurses doing Reiki on each other to get them through like some of their difficult cases and stuff. We would start to take care of the healthcare workers. I taught a yoga class at that hospital too. During lunchtime, a half-hour chair yoga class just to get the stress out of them. They didn't even have to change their clothes. Just get a chair and I'll show you how to do yoga in a chair.
Tell me this. You did the yoga thing. You got some law experience. I mean, you've done a bunch of different things, which is great. A few years later, I mean, you're a manager, but then you bumped up to that corporate role at UHS, over 26 hospitals, one of the larger systems in the country at that time. Obviously, there's several that have grown now. I'm sure UHS has as well. But what was that world like? I mean, was that a new, like totally new experience for you, or was it similar to something you
going from your family? Because a hospital is like a family. It's a marriage, and you get in there and everything's hunky-dory, the honeymoon period, and then boom, it hits you. The personalities, the people, as you said, the arrogance, the struggles, the stress. The thing about that, at the time I was single and my kids are all older, so it wasn't a big issue. And there was a corporate team of 7 of us. So there was quality and infection prevention and nursing and emergency preparedness, life safety, food and nutrition, and nursing. So that was the team that went out to one of these hospitals, and we did what we called a full book survey. We did CMS and Joint Commission standards as a team. And then we would write up I would take pictures and put them in a PowerPoint presentation, and we would have this detailed, report that said, this is why that was a problem. Who said that this is a problem? What Peter and I do now when we do these surveys is rather than the big cumbersome report, because they're not reporting to us, we go in and we do this prevalence survey for them. And then it's yours to figure out. But we do take the pictures, and then on the slide, we get a link to where will you find that is who says that's a problem? Who says that that's a violation of a standard? Whether it's you start up at federal, OSHA, and Department of Health, then the next layer is CMS, conditions of participation or conditions, financial stuff. Then you move down into the next layer are standard operations, associations make standards like ARN or APIC or, ASHI. And then you move down to professional societies who give their guidance and recommendations. And that's how you write a policy. What I find in infection control, people listen to the professional societies and don't listen to what federal or CDC or Department of Health is saying, because they want to spend the money to do things, certain things. So that's the structure. And that's from Institute of Healthcare Improvement. It's also adopted by Joint Commission, of how when you're doing surveys or looking at things in hospitals, what is that algorithm that you should be using in your mind, and staying firm with that. I was just writing recently on the IP listserv that somebody asked about percutaneous ultrasounds and how to disinfect them. And why is AIUM, which is the Association of Interventional Ultrasound Medicine, and APIC, recommending low-level disinfection? Yet the FDA, the CDC, and ARN and others are recommending high-level disinfection. And, I just gave the data, what I just said. You got to listen to what FDA says. This is what CDC says. But I wrote it there. I feel like I'm being ghosted. And I gave them the definition of ghosting and the reference to ghosting. I know what I'm talking about with the Spalding classifications. When it's a non-intact skin and you put in a central line or a dialysis line, you have broken skin. That means high-level disinfection. Even if you put a sheath on it over the device and use sterile gel, it can break. We know these things break. So we have that struggle at times where we know, but then we get overridden by recommendations, whereas the IPs shouldn't have been listened to. They should have stuck with FDA and CDC. Said, I don't care what they say. We're sticking with what the FDA and the CDC say. That's where you start, Anyways, that happens a lot, the challenges that we have. And you've got to be strong enough and assertive enough, not aggressive, but assertive, to be able to speak your truth. In yoga, that's satya, speak your truth and be heard. I'm heard because I'm authentic and I speak my truth. I'll never say something that I haven't investigated. Like, I've done the homework ahead of time. or collected data. That's data drives your program, whether it's process outcome data that you go out yourself and observe and collect the information and then present it to the surgeons, or clinical outcome data, which is NHSN. This is what we're seeing with the infections, and show the two of those if you're trying to change behavior.
So tell me I mean, you've obviously done a lot of different things. There's a lot of kind of overlap with different philosophies and whatnot. So I think you've got a really good picture of really the industry from a lot of different perspectives. And you've been at this for a long time. Where did we go wrong? Where did this, can you highlight kind of the steps to where you're we made this decision here as an industry, whether it was APIC or whether it was different people, but can you highlight some turning points to where you feel you know what, we made this decision here and I just don't know that it was the best, or maybe it was great, but where are kind of those defining moments?
I have my opinions about that. It's interesting. I decided to get a master's in education and health promotion rather than an MPH. And the reason I chose that is, hospital epidemiology is pretty contained. It's different when you're out in the community and you're doing outbreaks and what an MPH would give you. But when you're in a hospital, they pretty much prescribe to you how they want the data presented and the committees, and we want, these kinds of epidemic curves, or we want these kinds of cross tabulation charts. And I was so sick of describing the problem and fancy slides and, whistles and bells, which are even better today with all the AI stuff. But how do you change the behavior of healthcare workers? How do you change behavior of children even? So the education track I took was in health promotion, but I purposely took my electives with teachers. And I wanted to, because I had kids, I wanted to learn about, and it was tough because these were core classes for them, and learn about Kohlberg and, moral reasoning and how Piaget, and how do they actually teach in classes to sculpt children's behavior. So it was social learning theory. And it's from Dr. Albert Bandura out of Stanford University, role modeling and self-efficacy. If you role model the behavior and then you teach, you create a situation where you can increase the self-esteem of the healthcare, where you can do it. I'm going to role model it, but you can do this. Unit-based champion program is a good example. I'm going to role model to you what it's like to be an IP. And then you're going to, with self-efficacy, with education and role modeling and observation, you're going to be my eyes and ears in all these departments. It wasn't just nursing. I had unit-based champions in every department. And at the Baptist, I had 2 in the OR, so because there's so many surgeries. Then the next one is from B.F. Skinner, which was a Harvard social psychologist. And then we go back to the 50s, 60s with their research. And it was based on feedback, constant reinforced feedback. So data drives your program. Contracting. I will sign, or I will verbally say to you, I agree, I will do this. That's a policy. Or at a hand hygiene symposium, campaign, you can have them contract. I pledge that I will do better hand hygiene. Whenever you pledge to do something, it sticks with you. The body believes every word you tell it. So if you pledge to give somebody back money that you took from them, that loan sticks with you and with them. You're constantly reminded, I got to pay them back. I got to pay them. And you never forget, they owe me that $500. It sticks with you, even if it was not in a promissory note. And then the last one's called reciprocity. I'll give you something if you give me something in return. So those 5 principles became the theoretical foundation to my IP program. I have a website called creativehandhygiene.com. I just buy websites and set them up. You can believe all the websites I have. I even have one on Ebola infection prevention with all the original from 2014 documents from CDC on Ebola that you can't even find on their website now. Anyway, but creative hand hygiene shows, again, role modeling, the things that I did, and got budget to do these hand hygiene and annual bug beat fairs to stimulate creative use of those principles to get people to buy into my program. It was a marketing campaign, basically. Industry does it all the time. I'll give you this little pen, or I'll give you this little stuffed animal, and everybody runs to their booth at APIC to grab that little stuffed animal to bring home to their kids. And they get the attention of them. That's called reciprocity. So by using that, and I even used it at Mass General because I was in school at that point to do the bloodborne pathogen standard. We did multimedia kits and literally hand boxes that went out to all those departments with education all split on what they needed to do, their policies, their PPE, everything, and had unit-based champions even going back to 89 to 90. I've been using it since I learned about it. So that's what's missing, I think. Nursing has their own nursing theories that a CNO will say this is going to be the theoretical foundation to our nursing program. So that's one thing I think we need, a social learning theory base to say how are we going to change the attitudes and the beliefs of healthcare workers to care about infection prevention and control.
Yeah.
The second one is I was at the meeting at APIC when they came up with this idea of the title infection preventionist. And a group of us stood up who were trying to work towards this clinical specialist with a master's in nursing for our career, expressed our concerns that what does that mean? What does that mean in the structure in a hospital organizational chart? Where are you going to put them? Are they going to report to nursing? Are they going to report to the lab? Are they going to report to the ID department? Where are they going to go? And no, it's going to be like a hospitalist. They're literally like, oh, be like a hospitalist. They're going to be in a very high position. Well, when I went to UHS and looked at where the 35 IPs I had at that point, I went to HR and said, could you find me who they report to? They only found 10 positions. They couldn't find the others. They had no idea where they were. They were hidden in budgets. Some of them were reporting to the lab. Some were reporting to an ID department. Some had a hospital, depending on the size of the hospital. So I rewrote all the job descriptions with their approval and said, if they have more than 2 people in the department, they will become an IP director. So they go to director head meetings and department head meetings, and they can be part of the director energy of a hospital. If they're on their own, or they maybe have an administrative assistant that works with their manager, they manage the program, but they will then report under another structure. And I guess it depends on the hospital. I never wanted to report to quality. I stuck with nursing myself. Yeah. But usually they have gotten kind of put into the whole quality, which can be good or maybe not good. They have so much on their plate, quality directors directing quality programs.
It's unbelievable.
Yeah. But it's hard, especially with PSI, oh God, the patient safety initiatives and all the things the legal stuff, the risk management stuff, we get lost in that shuffle. So I really feel we should be equal, in my opinion, to a case manager department, a risk management department, a quality department, an infection prevention department, and maybe report to the CMO if you have a CMO. I mean, that to me makes the most sense because a lot of what we deal with is real clinical issues as well as them. So what happens?
Well, just in the career track alone, I've recruited in this since 2012, so I've kind of got a good picture of what this has looked like. And I guess for years, I was just kind of under the assumption, once you become an IP manager, maybe director, like natural next position would be quality. Director of quality, AVP of quality. And I have learned over the last, 10 years or so, that's just not the case at all. Yeah. Like it's not a clean transition.
You know what they should
Most quality directors know nothing about infection prevention.
They should have a track for COO, Chief Operating Officer. They know the hospital back into. We have been to every single department. We know how food is prepared. We know how labor and delivery is done. We know how radiology procedures are done. We know the operating room. We know central processing. We know nursing units. We know ICU. We know emergency service. We know every department because of that task analysis. We know what they all do. And so the COO is like that, the Chief Operations Officer. So a track that would move them in that direction. Let quality do that amazing stuff they do. It's overwhelming. Because they have this clinical lens that quality doesn't have. Quality doesn't have the lens that we have. They have not been, the trenches of the kitchens inside the freezers to look if there's mold up on the fence. Right? When I think of the stuff that I've had to do in hospitals, everywhere from the loading docks all the way to the ICU and the OR, it's a fascinating job. It's one of a kind in a hospital. There's nobody else like us. So that's what I feel is that the track would be better off into administration to more the COO arena and not so much the quality, as I said. But some people they have moved up that direction, but not very often,
It's rare.
Yeah, it is rare. You're right. And so that was the problem with, do we call case managers CMs? Do we call risk managers RMs? We call quality directors QDs, but we flippantly, oh yeah, the IP, go get the IP. You know,
Yeah.
it bothers me. Haven't been in this job. I want to be called the director. Go get the director of infection prevention. Go get the director of quality.
And what you're saying too, like it's amazing the amount of HR departments that I work with, or even C-suite, that, like you're saying, don't have a clue the reporting structure of this
Yeah.
person, what their title is. They just, yeah. So
And then the other
yeah,
problem is, so now you have it as a career that was primarily nursing, with nursing salaries. They have to pay us as a nurse if we're a nurse. And then we started to notice this movement of the masses of public health that don't have the clinical background. They've not been at the bedside, and they have the amazing stuff they learn. I don't knock it as far as, you know, the epidemiology that they can do and so forth. But I've been with them in like an ICU, and I used to do it on purpose, and I did it to role model this. And we'd do our rounds, and the MPH with the deer eyes, because they didn't go into the ICU very often. And I said, okay, get a pair of gloves on. We're going to start looking. And they're like, what? I said, I want you to show me if the Tampa evidence seal has been disconnected. So I would do a prevalence survey when I was doing my survey. Tampa evidence seals, where are the A lines, subclavian, IJ lines? What about the respirator? What about the toilet in the room? You know, what about irrigation solutions? What about flowers, cut flowers in the ICU? I would take them through a room and show them all the infection, potential sources for infections in that unit, in that room. And they would almost die. They're like, well, where's the Tampa evidence seal? I said, well, you got to go to the bed, and you got to spread the legs, and you got to start digging up. It's going to be close up towards the inner thighs. They almost dropped dead. I mean, but some of them were like, I've never even touched a patient. We're going to touch a patient. Come on. Now, show me where the A line would be. I had no idea what an A line was. Show me, is that a subclavian or an IJ line? And show me, what's the concerns about the tubing? What do we have to watch out for respiratory tubing? What about all of these IVs that are here, which, you know, in an ICU, especially cardiac or transplant, like, what are we looking for here? You know, that should be the caps, the alcohol caps. What about the toilet? If there's a toilet in the room and they're throwing the feces or, you know, urine down the toilet, what are you worried about with the plumes? Well, there's a curtain. Right. They should have the curtain turned so they can confine and contain it. Stand there and watch to see if they take the oral secretions, if they're doing oral care and helping the patient with some mouth care, and they take that and pour it down the hand washing sink in the room. Or the dirty flower vase that's been sitting on the windowsill incubating all day with dirty brown water in it, and pour it down the hand washing sink. What do they do when they take slipper socks off? Now, this patient's walked all over the dirty floor, C. diff, you name it, gets in bed with all those dirty socks, and you go over and you take them off. The nurse takes them off. Do they wash their hands afterwards? Do they realize how contaminated those are? That's what's missing, that clinical, because I've suctioned, I've put a catheter in, I've put IVs in, you know, I worked in a NICU just for about 6 months before I went full time into the infection control. So I know a lot of that clinical stuff that you have to watch out for your eyes and ears as a nurse at the bedside. And so we've got to do better training. I think they need practicums. They need clinical practicums and I know some are doing it. Some of the hospitals get it. And we hear it at the corporate IP directors group, that they've now started to set up where they would buddy up with, you know, maybe an ICU nurse or an OR nurse. We tell the OR, when Peter and I speak at AORN, and which we do a lot, we tell them not only show the collaboration, role model this collaboration between the two of us, but give them an orientation like you do your new nurses. Take them and let them see a total knee, a total hip, a colorectal case, an abdominal hysterectomy, because they report those. And, you know, in C-section, spines, let them actually see and have somebody in infection prevention who understands what are the risks in that type of surgery. Explain that to them. You know, what's bone wax in cardiovascular surgery? Why could that cause an infection? You know, what's happening with the doors opening and closing? But they're taught to look at PPE, all these low-hanging fruits. You know, there's stuff that goes on in the field that they have to know to figure out an outbreak.
So let me ask you this. I'm curious your answer on it. Like if you could make, let's say you're in a 500 bed hospital, you're a director, you are yourself, and you could build an IP team however you want, 4 IPs. What would their backgrounds look like? I mean, what makes up your ideal department?
First of all, I was what'd you say, 400 bed hospital, 500 bed hospital?
500 bed hospital, you're a director.
This whole thing about 1 IP per 100 beds needs to go out the window. You need more IPs than 1 for 100 beds. So
I
first,
think
yeah,
I think
we need more.
obviously I think APIC's got a calculator now that's more
Yeah,
definitive. I think
yeah.
Rebecca Bartles put out 1 to 69, I think, back 2018,
Yep, yeah.
2019.
So we need
Um,
more people in the job. We need to have the tasks like NHSN, that kind of stuff, delegated to somebody who's not the educator, the consultant, and the researcher. So let them start there. Like I said, maybe somebody's
so
going
you'd outsource
you can
surveillance to
outsource
some
it,
level,
right? We did that at UHS. We
whether it's an internal
yeah,
corporate team or just
yeah, we had
somebody,
a
somebody
company
that's
that
not the
did,
IP.
yeah, we had a company that did the surveillance, outsourced it, and then we had a corporate epidemiologist that worked with them to oversee all that information. Yeah, you can do that to get them to be able to get out of their desks and their jobs. I just have my bias because I'm a nurse, and I know we get hit with that a lot, that the IPs that are MPHs feel like, why is it that every job wants a nurse? You find that very often that they still want to get a nurse. I'm not saying all the nurses are going to be great either. They need a lot of education as well. But at least you have that clinical aspect that they do know how to talk to patients. They are like a doctor will talk to a doctor in a whole different level. As a nurse talks to a nurse, we have our ways. And then that's their struggle sometimes, is that maybe they're not respected, or they're like, well, they don't have any clinical background, to understand some of these things. It does come up. You can hear it in the meetings and so forth. Now, I'll
Yeah.
be honest with you, Peter and I have gone to a couple of hospitals where in one situation, the director didn't even know where the OR was and did not tour with us. And then the other
Wow.
one did not tour with us. Another one that didn't, but assigned us, so they do sometimes have somebody, often a nurse, that they'll designate to the OR. So sometimes we'll get IPs from the OR who are nurses. And I think that's great because they really do know all the sterile processing and the operating room. And they'll assign them just to be to the ORs. And that works
Gotcha.
out great, I think. And you're seeing that more and more in the big hospitals, that you'll have an IP with a specialty in surgery. But that kind of opened our eyes, that the intimidation they feel, because both of them were not nurses, and they that may be one of the reasons that it's an intimidating place to be, believe me. You got to remember, all they deal with is their eyes. I call it the third eye, right? And they shoot shots of eyes, looks at each other, and you can't see their face with the mask on. You can't see any jewelry or clothing to intimidate or accentuate your personality. It's eyes, and
Yeah.
it's all up here, their energy. So you have to just figure out ways, like how I did it at the Baptist and at Mass General, is I would go to the staff meeting once a quarter and give a 10-minute update on infection prevention. What did the data say? What was going on with the SSIs? And what were the projects we were working on? Were we implementing a new Tampa evidence sealed indwelling Foley system? Were we implementing a new wound care program? They would, because they're behind those closed doors and they get left out. They don't know a lot of times what happens out on the nursing unit. So I would try to be that networking interface between what we were doing outside the OR and in the OR. And that worked out well, because then when I go to the OR, they knew who I was. Oh, hi, Maureen's here. Everybody wash your hands.
Yeah.
Yeah. That's why you want
Nice.
unit-based champions. I'll give you an example. Back in 2007, all of a sudden I started to have these total knee infections, and they were with alpha strep and strep viridans and some coag negative strep. And I'm like, these are weird. This is not the typical Staph aureus or MRSA or even maybe a gram negative, but usually it's the gram positives. This is mouth. This is like stuff you typically in the environment of the mouth. So I asked the unit-based champion, I said, I want you to go in and look and it was just knees. What's going on with the knees? She calls me up. She goes, figured it out. They just start to use this new pain cocktail, we call it. And it's Toradol, Marcaine, and Duramorph. And they are putting that in the knee so the patient has no pain for like 2 days post-op. But what they were doing is take one syringe and needle into one vial, squirt it into a sterile specimen container off the field, by the way, not in the 3 feet around the bed, off the field, the dirty zone, we call it. And then they take the next one, squirt it in with the same needle. And then the next one, squirt in with the same needle. And then they would pass that specimen container to the field. And then the surgeon would mix it up, draw it up, and put it in the knee. Now, all that's done by pharmacy now, 10 years ago.
Yeah.
So you have to have those eyes and ears because they would, if I was in there, things might have changed, like it's called the Hawthorne effect. We would have people be influenced by our presence. So you
Yeah.
have to have that group of champions with you, and not just in nursing, they're all the departments. And then our job is to educate them and provide feedback and reinforced education and feedback, contracting, role modeling, the whole social learning theory. It works beautiful.
Yeah. Tell me this then. I mean, like I said, we've seen the infection prevention industry kind of take its turns here. Um, do you have anything within infection prevention now that you're particularly optimistic about, or any kind of glaring concerns that stick out that you have a solution for it, but like we've got to solve this soon?
Well, this conference I attended last week, it was really fascinating, called Surgical Site Outcomes, SSO. And they brought in surgeons from around the United States. We had a surgeon from the UK who was a hepatic biliary surgeon who actually started this program in the UK, and they're trying to introduce it to the US. And it's called the DISH program. DISH stands for dehiscence, infection, seroma, hematoma. And it's an app, and surgeons will follow their PAs or nurse practitioners, whoever they assign this to. It's most likely not going to be the surgeon, but will be their ancillary staff, will follow the patient for 30 days and record, did they have, it started off as a seroma, maybe on 3 days post-op, and they drained it, and then it turned into a hematoma a couple of days later, and they had to take them into the OR and do an IND and debride it. And then lo and behold, now it ends up being an infection, or they dehisced, and then they got an infection. Because what's very difficult if you don't have that clinical background is to understand, if you've not seen a dehiscence, if you've not seen seromas or hematomas getting drained, if you've not seen INDs, we probably are not recording things, with NHSN has that strict criteria. We're either missing some of them or we're overcalling some of them, which is what I heard from the surgeons. They feel that IPs are overcalling their infections, that was not it really was a hematoma, and it was just contamination in the culture, and yeah, it looked like it was purulent, but it wasn't. It was just what blood looks like when it gets old. I mean, it was fascinating, the discussion. So they're trying to get this to be how we would then record wounds post-op, the DISH program on this app, and they would follow orthopedics out to the 90 days because they send them home on day one. I mean, even total joints now are same-day surgeries, or at least maybe one day if they have a lot of risk factors. And so they don't have the pleasure like they had in the old days of doing roundings and seeing their patients like they used to. And so this might be a way that as that patient comes in to the system, comes into a clinic or the emergency room with one of these DISH, then that would get recorded in the system. And it would be a better way to really monitor what happens to patients post-op. So I was really, really impressed with it. And it was just something new. They have had an 87% reduction, if I remember it right, in excess patient days. They have reduced antibiotics use. They have reduced infections with this system. And so they've got a paper they're waiting to see if it's going to get accepted at JAMA surgery. And if that does, that's an introduction to the program and the methodology of how it's done in the system. And then the hope would be that it would be adopted in hospitals throughout the country. So things like that really excite me, to see collaborative, real multidisciplinary work of where we're trying to solve a particular outcome in patients.
Yeah, no, that's great.
Yeah, the other thing I've been involved with is aerobiology, and very interesting companies. There's one in Sweden that has what's called temperature-controlled airflow. Laminar flow, we know, doesn't work in reducing infection, so people are still wasting their money putting them into new systems, or new hospitals they're building, or new ORs. It changes the temperature 2 degrees colder, which surgeons love. And by that gradient change, it pushes all of the air down to the floor and out 4 exhaust vents, not 2. But they can't be occluded. That's a big issue we find in ORs, that people put equipment in front of the exhaust vents. So an IP should be up in the ORs looking for that. Are they occluding, and the dirt can't get out of the room? The other they did smoke studies with the smoke gun. And oh my God, you should see this in the dirty zone. When they take the smoke gun and stop the smoke, it gets pulled up. We're watching it go up to the ceiling. The heat of the overhead lights is a thermal convection force that heat rises, pulls it up and dumps it down with the laminar flow, dumps it right into the incision. So that's why we recommend antimicrobial sutures. We recommend surgical irrigation, flushing the tissues out before you close them up and sealing them with topical skin adhesives or things that now they're going to go home and have something that's really sealed, or a dressing that will stay in place for, like, say, 7 days. So it's things like that. I'm working with another company that has silver dressings that are different, all the different types of silver dressings. So that's what I do with the vendors. Is, like I said, I only have 4 of them that I work with, and we provide webinars and consultations, and sometimes do expert exchange with staff or surgeons at the hospitals, and give them our experience and our recommendations, and try to help them out that way. That's what, as consultants, what we do: perioperative and infection prevention consultants. Yeah.
So certainly things to be excited about. Where are your concerns? What?
I think the key thing in healthcare right now is it doesn't work well in this country. I mean, and I don't think the social approach, also what goes on in Canada and other countries, works as well. It's like, what is the magic to taking care of people? There was something I saw briefly that said, why don't we give the patients the money rather than give the hospitals the money? The government give it back to the patients, to, if you stay well and you take care of yourself and you don't use health care, give them a kickback, like, hey, you're going to get $1,000 this year because you didn't use your health care. You were kept yourself healthy. There's got to be some incentive for the patients. We incentivize the doctors to do things faster and quicker with throughput. My goodness, you're lucky you get 15 minutes to talk to a doctor. Or their salary's going to get chopped, So we've got to figure a better way for the prevention part in healthcare. And I think that is what they're trying to talk about and look at, and try to get a healthier group of Americans. But healthcare right now just seems to a lot of us, just with private equity getting involved, buying up these hospitals and health centers and so forth. The bottom line is money. It's, it's just making more money. It's the energy of greed. In yoga, we talk about these 5 dragons, and one of them is intense fear. Like, you've had a period in your life where you were absolutely petrified, but you got through it. Then we have lust. You might have it wasn't love, it was lust, and it was just an affair or something that happened. You got through it. Then you have greed. You want more and more and more, the bigger house, the better car, and competing with the Joneses and all that. And then it finally just gets to a point where you just want abundance. You don't want any of that. Then there's codependency. You're addicted to somebody else. They're addicted to you, or a substance. We have a lot of addictions in this country. And then we have ego and vanity. Yeah. So if you think about it, we have those 5 dragons really operating in our culture. There's a lot of fear. There's a lot of lust and sexuality and porno. And there's a lot of greed. And there's a lot of codependency and dependency. And we've got ego and vanity operating. And so you mute that, you transform that with practices, spiritual practices, to get you back in touch with yourself.
I have one thing that I've been curious about, and I just want to kind of hear your take on it. But tell me more about this, like, directors group you guys have. Is this just like a fun text thread that you guys, is just like a buddies group chat? Is this like a lot of structure? I mean, what goes on here? What is everybody else in the world missing out on by not?
I'm actually thinking now of setting up an IP consultants group, because they've let us stay on the group. Those of us who had been in corporate roles and then retired and went into consulting. But when we started, like I said, we had 10 people. And so we would just email each other questions and share things. Oh, did you see this that just came out? So it was all by emails. And then I introduced Sue to GoDaddy and how to buy a web domain for $10. So we bought a web domain for the surgical it was called corporate IP group. It was called .net, maybe. It doesn't exist anymore. So we were able to then upload on there the list of who was on the group. And if you wanted to share any templates, so like I put up all of my job descriptions that I wrote for UHS, the director, manager, coordinator, and data analyst. Those are the 4 positions that I wrote. And other people did. And then we started to add policies and procedures on it and just share with one another on this contained group, because nobody knew about this website except for us. And so then it's started. Every year we would meet at APIC, and we got APIC to agree to give us a room, because those rooms cost money, and that we would have a meeting face to face once a year with a very detailed agenda or things that that they wanted to discuss in person. And from there, APIC then got involved, heard about the group, and thought, wow, this is wonderful. And we wanted to, at first it was like, could we get an APIC listserv like we have for IPs for corporate and system directors? So they did that. They set that up. We don't use it very much because now we're on Teams and we meet every month. And on the Teams is where the chats are of what are the topics that you want to share or a program you want to share. You know, I told them about that SSO meeting in case any of them wanted to attend. They could have attended. So it's really worked out well because now through in the Teams, we can all upload documents. If there's a paper or somebody's asking a question, I tend to stick with the surgical SSI questions, but it's fascinating because you learn a lot and you hear the struggles and the challenges they have. Especially like at a local hospital, for instance, somebody might see a product at APIC and say, oh my God, this would be great. We want to get this in. But then they're part of a corporation, so they got to contact the corporate people and say, hey, can you be our champion to get this in? And so then they've got to navigate through the corporate channels of value analysis and clinical value analysis nurses. And I've been there, I've done it. It's a lot of work. So you really have to have good evidence, good, strong evidence to say, yeah, I'll take this on. This should be used by everybody in a hospital, And so that's how it works, like we'll then talk to each other. Hey, have you implemented a nasal decolonization program? What are you using? How many of you using, what kind of antiseptic irrigations are you using? Are you using the plus sutures? Are you using, what are you doing for pre-op cultures for MRSA, MSSA? And we all then share. So and now APIC runs the meeting. So APIC sends out the, request, and books us every single month. One of them we do in the morning on a Thursday, and the other one we do at 2:00. We alternate the months, to help people's schedules. So it's a great group.
Has that been a relief to have APIC run it, or
so APIC
do you feel like you've lost?
Yeah, APIC runs it. So if somebody is a corporate director or a system director, I don't know if it's more than 5 hospitals. I don't know what the criteria is now. They get in touch with APIC, the person that's running it or the person running the corporate, and then they have to go through a vetting process to see if they meet the qualifications to be on the group. Yeah.
Gotcha.
It's cool to see 10 years later what happened from that little
a long
meeting
way.
that nobody was at.
That's awesome.
I know.
Like I mentioned at the beginning, like most people that are going to be listening to this are people actively trying to grow in their profession or just kind of toying with it or kind of seeing what infection's about. But having done this as long as you have and seen it from so many different perspectives, do you have any, I don't know, words of encouragement or anything, any advice you would give to kind of people that are just kind of getting started in their infection prevention career right now?
Yeah, I think if they did what I did, which was to network with local IPs that are experienced. I used to do orientations all the time. I would offer to take people and they would spend a month with me. I had somebody from Singapore that spent a month with me. And just they would go to all of my meetings. They'd do all my rounds with me. They would sit and figure out in those meetings with my ID doc, how do we call an infection? They just were, glued to my side and became an IP for a month or so. That's the best thing. And if there's somebody who doesn't have a clinical background, then ask the clinical educators in their hospital if they can round with them, or in the operating room, the clinical educators in the OR. And could you set me up an orientation program? And put the ego aside. I don't know what a total hip looks like or a total knee. I'd love to see it, and could you do some training for me? Or even anybody. I mean, you don't have to be Masters of Public Health, but an IP that doesn't have an OR background, and start to learn about their hospital. I would also suggest to go back and do that task analysis all over and say, you know what, I want to see if these are all the procedures. This is so outdated. When's the last time we actually redid this task analysis? And go into all the departments and with a clipboard with what you have and say, what else are you doing here that we don't know about? And that gets you in the door, gets them all talking. And, you talk to the director first or the manager, and then you go out and you observe. So you actually get a much better orientation of what goes on in these departments that is going to click in the back of your little library in case you have a problem. You're like, oh, I remember seeing such and such in that department. Let me see if that's causing an infection. So that's another one. But I really think it's that collaboration, making sure they're part of APIC chapters, going to the chapter meetings. Or we have a Boston local group, another group I started back in 2004, with 4 of us when we started. Now we have 160 or so people on this list, and I manage the list. I role model, and I am the mother guru in Boston, where I manage that list. So if anybody changes a job, I know where they went. I know who they are, their phone number, their email, and I send it out every 2 weeks with the update. I've been doing this for 20 years, and I didn't stop. See, that's reinforcement. A lot of times
Yeah.
people will do something and then give it up. I'm like, why did you give that up? We lost interest. I don't. I'm committed to that group to keep that going until I completely retire. I don't know who will ever take it over, but it keeps them cohesive. And we just email each other in that group, but we meet every other month virtually. We're not part
Gotcha.
of it's not an APIC chapter. We have our APIC New England chapter and we go to that, but this is just it's mostly Boston or, the suburbs as well, but it's a great group because you get to hear things that are going on in the city that you wouldn't normally hear at an APIC chapter meeting.
Yeah.
So
Yeah.
that's something people could do is set up a little local group of IPs that just talk to each other on an email and
Yeah.
share information, when you need some help. But don't be shy about going out and asking for help. That's that fear I was talking about, dragon of fear. Like, they'll
Yeah.
know the imposter syndrome. Fake it till you make it. I mean, really, that's the way to get through this. But behind the scenes, if you're feeling like you're an imposter, get out there and try to do things that make you authentic. That you do know what that looks like or how to do that.
Great advice. One follow up on this, and then I promise I'll do my last question. The follow up on that, when you would interview people and hire IPs, infection preventionists, sorry, when you would go to hire these folks, what did you look for? I mean, what skill set or personality type did you look at and be like, okay, yeah, that's an IP, or oh, that's she's not going to make it. Like, what do they have to have that just kind of tells you right off the bat that, like, you know what, they have what it takes to make it in this
they have to be assertive. They have to have tough shoulders and not have some emotional intelligence. This is a tough job. You're going to get bashed around, and you can't take it personal. Read the book, Don Miguel Ruiz, his book on the 4 agreements. One of them is don't take anything personal. It's not your stuff. Like I remember as an example, I had one of the ID doctors who was going to now be the head of the infection control committee. And I saw him in the cafeteria and I said, oh, Dr. So-and-so, could we meet and have coffee sometime? I can go over the agenda. Or what? He goes, let me get something straight with this little finger in my face. Let me get something straight. I don't go over the policies. You do. You bring those to the committee. That's not something I do. So I stood back and I went, okay, let me get something straight. I mirrored back to him what he did. Let me get something straight. You're not going to meet with me to go over the policies ahead of time and waste my time? Is that what you just said? He just goes, I said, and I smile. You're not going to get to me. And he said, well, I didn't mean it that way. I said, I didn't think you did. Do you want to meet? I would jump in front of them if they didn't sanitize their hands. I was to go out and I'd say, you did sanitize your hands, right? I did. I did see you go over there and sanitize your hands. And they're looking at me. I said, no, you didn't. Go do it. You have to have, when you see that creative hand hygiene and see what we did, you have to bring some humor and levity into this, and not be like, snapping their hands and the mother kind of a thing. And just do it in a way in which you get respected and you can survive. It's a tough job. Very, tougher than most people realize because we're dealing with all different personalities in all those departments. It's a lot. So just anything they can do to keep themselves taking courses, going into hospitals and seeing if you can shadow somebody for a couple of weeks and give it that time. It's one thing to take Epi 101 and 102 and get your CIC. That's knowledge based. I was on the original task analysis that developed all of that. We had 1982 to 84, 3 articles, part 1, 2, and 3, that talk about the task analysis that then became the CIC exam. And what were people doing back then for their jobs? And I almost wonder, like, is it the same? Are we still doing what they did back then versus today? And the CIC. So that, and in that, we talked about this knowledge does not mean competency. Like we do competencies on nurses all the time. Well, we need to do competencies, which they do. A lot of the IPs in the corporate level talk about those competencies and they have checklists and so forth. But observing them to see that they actually do know how to lecture properly. They use, educational theory and they do know how to do rounds and collect data. They know how to interact appropriately and emotionally stable with staff and not get intimidated, or get angry and get defensive. Yeah, there's a lot there that we need to help them with. Yeah, but I admire them. I admire anybody in this job. I think it's like I tell people all the time, you're like the premier in a hospital. There's no one like you. No one does what we do. Go into every single department and oversee every surgery, all kinds of procedures. That we're there as that interface between that patient and that group of people getting infected. We're that firewall.
That's one thing that I've learned through this whole kind of interview series is, you guys seem to have a better understanding of the full hospital than really anyone else.
Yep. That's why there should be a COO or up in those levels, rather than the slice of quality, which has specific things that they have to do for the government, for standardization standards like Joint Commission and so forth. And, and then they get intimidated sometimes when we bring things to them because they don't know. They're trying to direct our programs, and you could be a manager and you're like, but I'm directing it. And they take credit.
Yes.
That's a big issue, is that often they get the credit for all the work that we do. And I want them to get the credit. I want them to direct their own programs. And like I said earlier, be equal to a case manager, risk management, quality managers, and infection prevention managers or directors, depending on the size of your institution. And all of them feeding up to the CMO, ideally. Sue Barnes and I did write an article in Prevention Strategist, I think it was, years ago, about what the structure would look like. I forget what year we put that out, but that was what we stated way back then, that's how we felt the structure should be.
Thank you for joining us on this episode of Voice for Infection Prevention. We hope you found our discussions informative and insightful. Remember to subscribe to our podcast for more conversations with experts in the field, and don't forget to leave us a review to let us know what you think. For additional resources and to stay updated on the latest news in infection prevention, visit our website at voiceforip.com. Thank you again for listening. Until next time, stay safe and continue your commitment to excellence in infection prevention.